So the infection of bladder is cystitis, infection of urethra is urethritis, and infection of prostate is prostatitis. So what are the symptoms? How patient present in our clinic with UTI? Like what they say, patient presents with complaints of burning micturition, dysuria, which is painful urination, increased frequency of urination, hematuria, which is presence of blood in urine. Patient can have fever, nausea, vomiting, and also the flank pain. So after the symptom, we examine the patient. So first we go for general physical examination. So in that we assess the vitals of the patient, which is the heart rate, blood pressure, temperature, and the respiratory rate. Then we go on systemic examination. So while we do the abdominal examination, we can have tenderness in the flank region, which is costovertebral angle tenderness. That is very much suggestive of pyelonephritis. Then patient can have urethral discharge in case of urethritis. And while we perform DRE, digital rectal examination, patient can have tender prostate, which is a sign of prostatitis. So on lab investigations, we'll go for urine analysis and then followed by urine culture. In urine analysis, we are going to see presence of white blood cells and the red blood cells. So after urine analysis, we go for urine culture. Urine culture comes positive in case of UTI. So the most common pathogens which are responsible for infection like cystitis, prostatitis, and pyelonephritis. The most common pathogens are E. coli, Staphylococci, Proteus, Klebsiella, and Enterococci. These are the very much commonly involved pathogens in the pathogenesis of urinary tract infections. However, the pathogens which are responsible for urethritis, which is also the sexually transmitted disease, they are Chlamydia, Trachomatis, and Neisseria gonorrhea. So, in case of cystitis, there are two types of cystitis: complicated cystitis and uncomplicated cystitis. Uncomplicated, which is simple cystitis, is seen in healthy female patients with no signs of systemic disease. However, the complicated cystitis is seen in most commonly in males, or it can be female with comorbid medical conditions. And there can be recurrent cystitis as well. So the complicated cystitis is by definition is seen in healthy women who are non-pregnant, who have no signs of fever, no nausea, no vomiting, and no flank pain. And diagnosis is done basically by urine analysis and urine culture. So treatment, we need to give antibiotics for almost 3 to 5 days. And the risk factors for uncomplicated cystitis is sexual intercourse. And in those patients, we recommend postcoital voiding or prophylactic antibiotics use. Then the complicated cystitis is seen in female patients with some comorbid conditions like which have neuropathy or the diabetes mellitus. It can be seen in all male patients, patients who have indwelling Foley catheters like prolonged catheterization, and patients who have urosepsis, or patients who are hospitalized for longer durations. Again, diagnosis is made by urine analysis followed by urine culture, and we also do further labs like CBC, we need to see TLC and other the creatinine level as well. Now the treatment of complicated cystitis is antibiotics for about 7 to 14 days. And most commonly we use fluoroquinolone groups. And in male patients, we need to give them for 2 to 4 weeks. Now what are the special cases of complicated cystitis? It can be developed in patients with indwelling Foley catheters. So in those patients, we try to get rid of the Foley catheter as soon as possible. And we only treat them when the patient when they have symptoms like fever, dysuria, burning micturition. So how we diagnose it? Again, presence of leukocytes, white blood cells on urine analysis. Patients with indwelling catheters, they are frequently colonized with great deal of bacteria, and they should change Foley catheter every month before obtaining urine culture specimen. Then candiduria, it frequently occurs in patients with indwelling Foley catheter. And if this candida, it grows in urine, try to get rid of the Foley catheter. And we treat them only if it's symptomatic. And if need to treat, we give fluconazole, which is antifungal medication, for about 2 to 3 weeks. Then recurrent cystitis. Before labeling the patient with recurrent cystitis, we need to make sure that the urine culture is positive. And we also need to consider other urological workup, like with some labs and also with radiological investigation. And again, in those patients, we treat patient for about 2 weeks, up to 14 days with antibiotics. Now the pyelonephritis is infection of the kidney and is associated with constitutional symptoms like fever, nausea, vomiting, headache. Diagnosis is again made by urine analysis, urine culture. Treatment, we give antibiotics for 2 weeks and we need to hospitalize the patient and start on IV antibiotics if the patient is not giving any response on oral antibiotics. So pyelonephritis can also end up and can develop certain complications. Complications can be perinephric or renal abscesses. Basically, what is abscess? It's collection of accumulation of the pus within a contained cavity. So we suspect formation of abscess in patients who are not improving while giving antibiotics. Now, how we diagnose the abscess? We diagnose the abscess with the help of renal ultrasound and CT scan. If again this abscess is not responding or is not improving with antibiotics, we need to give surgical drainage under anesthesia. Now, the other complication of pyelonephritis is basically formation of stones, that is nephrolithiasis with UTI. We always suspect these in patients with severe flank pain, and they also need urological workup like imaging, ultrasound followed by CT scans. Then the prostatitis. Prostatitis is basically infection of the prostate gland. Obviously, it's only seen in male patients because female, they don't have prostate. So patient can have pain in the perineum, pain in lower abdomen, testicular pain, penile pain with ejaculation. They have also the symptoms of bladder irritation. They have symptoms of bladder outlet obstruction, which is poor flow, hesitancy, sense of incomplete bladder evacuation. And sometimes they have hemospermia, which is presence of blood in the semen. Now, how we diagnose it? Typical clinical history, patient have fever, chills, dysuria, malaise, myalgias, pelvic or the perineal pain, and the color of urine is changed, and it's a certain specific smell in the urine. On examination, while we do DRE, we can find an edematous and tender prostate gland. Again, we need to give urine analysis and urine culture specimen. So what about the treatment of prostatitis? Treatment is again with antibiotics, which is trimethoprim or fluoroquinolones or other broad spectrum antibiotics for again 4 to 6 weeks of treatment. So prostatitis has to be treated for up to 4 to 6 weeks. Now, what are the risk factors in patients who have prostatitis? They can have trauma, sexual abstinence, or the dehydration. Now, the urethritis, which is infection of the urethra. Now, the commonly involved organisms are chlamydia and Neisseria. So, chlamydia trachomatis is frequently asymptomatic in females but can present with dysuria, discharge, or pelvic inflammatory disease. Again, we will send some labs like urine analysis and urine culture. On pelvic examination, we send discharge from cervical or the urethra for the swab. And then chlamydia screening is now recommended for all female patients under the age of 25 years old. Now, how we treat them? With azithromycin and doxycycline. Now, Neisseria gonorrhoeae, it also presents with dysuria, urethral discharge, and pelvic inflammatory disease. We send urine analysis and urine culture. On pelvic examination, we can see some discharge from the urethra, and then we send the discharge for gram stain and the culture. Now, how we treat Neisseria gonorrhoeae urethritis? We can treat with ceftriaxone, fluoroquinolones like ciprofloxacin, levofloxacin, ofloxacin, and one should always treat chlamydia when treating for gonorrhea because most of the time these both organisms, they are there simultaneously. So to conclude, antibiotic choice and duration, they are determined by the classification of UTI, like which area of the urinary tract they are involving. So the biggest or the most responsible organisms or the pathogens for UTI, they are E. coli, Staphylococci, Proteus, Enterococci, and gram-negative bacilli. Remedial screening is now recommended for all female under the age of 25 years since this infection is asymptomatic and the risk of